So when we look at our echo, right, just so that we have a nice basic approach, I like to remember the 5 E's. And so Dr. Shapley said quality. So a nice way to remember, and I like very simple things, is your left ventricle should always be bigger than your right ventricle. That's nice and normal. When I'm looking at my different views, right, I want to be able to figure out which views are my best ones for equality. And so let me just, sorry, back up for a second. When I'm looking at equality, I'm trying to really look for signs of right heart strain. So if I have somebody that has like a PE or is coming in with symptoms of a PE, so say shortness of breath, chest pain, dyspnea exertion, God knows how many PEs I've admitted to cardiology. I'm very sorry. Very good at missing them. When I do my echo, right, I'm looking for signs of right heart strain. So the first thing I want to look for is equality, and knowing that my left ventricle should always be bigger than my right ventricle. And so being able to figure out what view I can see my left to my right ventricle is going to be really important for me to figure out which one is going to be my good view to look at. So looking at our 4 views, right? The best view to look at your equality is really going to be your apical 4 chamber. And I'm going to tell you this view is going to be sort of like your best view for everything because it's just an awesome view. It's the poor man's TE. And when we're looking at equality, you want to be right about the level of the valves. And you're looking just at the inside. And so again, LV should always be bigger than RV. Whenever they are equivalent in size, you now have right heart strain. You can get this with very large PEs. You can get it with RV infarcts. You can get it with like chronic pulmonary hypertension. So just understanding that you can get it with both acute processes and chronic processes. And on basic POCUS, it's very difficult to tell the difference. There's like a quick one we'll go over. So apical 4 is going to be a good one to look at my equality. Parasternal short is not great for equality, but is going to be really good for right heart strain. And I'll go over the signs of it in a second. But really what I'm looking at is my septum for this one, because my septum is really going to tell me the health between my 2 ventricles. Because if my right ventricle has a higher pressure than my left, which it never should, right? The right ventricle should always be a lower pressure system. It's going to cause the septum to now bow into my left ventricle. And now I get a D-shaped left ventricle. So when I have right heart strain, whether it's acute from like PE or an MI or chronic from like pulmonary hypertension, and the right ventricle gets overloaded, whether it's volume or pressure, it's going to at some point exceed the pressure of the left ventricle, and it's going to cause that septum to then shift. And so you might not be able to compare exactly right to left ventricle size, but you can get an idea if the right ventricle is really large in this view. And I can tell you if the right ventricle is overloaded compared to the left. We'll go through right heart strain in a minute. The other really good view for equality is also going to be your subxiphoid. Again, we're looking right about the levels of the valves. And then your parasternal long is a little bit special. So we're not really comparing the right ventricle to the left ventricle here, but we're actually comparing what we say the 3 musketeers. So you're looking at your right ventricle to your aorta to your left atrium. And all of these 3 should be equal. So we call that 1 to 1 to 1. So if my right ventricle is bigger than these 2, that's going to tell me RV strain, acute core pulmonale, something like that. If my aorta is really big and they're coming with chest pain, now I'm thinking aortic dissection because there's an aneurysm. If my left atrium is really big, I'm thinking like mitral regurg, mitral stenosis, or some diastolic dysfunction. So it's going to give me some information about the heart. So parasternal long, these 3 should all be the same. So we got a 1 to 1 to 1 ratio. In my parasternal short, my LV should be bigger than my RV, and my septum should be pointed in towards my RV. In my apical 4, my LV should be bigger than my RV. And then in my subxiphoid, my LV should be bigger than my RV. The big thing to understand about the RV is that it kind of looks like this. And so depending on where your beam is angled, your RV is going to change in size. So if my beam is angled this way through my RV is going to look really small to my LV. If I'm here, now my RV is going to look a bit bigger. And then if I'm down this way, it's going to look small again. So you just have to make sure that when you're doing your RV assessments, that you're like kind of fanning through the whole heart, find where the RV is the biggest. Do you guys want to go through findings for right heart strain quick, or do you want me to go through all the 5 E's first, and then we'll go through like tamponade and PE?
For the rest of the
I'll
5
go for
E's.
5 E's.
5 E's, okay, perfect. All right, so we got equality. What else do you guys think there is? Just think about what's the, what?
Effusion.
Effusion, perfect. All right, so we got equality, the next one's effusion. So when it comes to effusion, it's important to know where to look. Because if you're not looking in the right spot, you're gonna get messed up, or you're gonna mistake a pleural effusion for a pericardial, or you're gonna mistake a fat pad. So if you think about the way a person is laying, right, here's their bed, here's their body, and the heart is sitting here. And for our parasternal long and parasternal short, our echo, our probe is up this way. So where's the dependent portion of the heart, right? If there's fluid in this pericardial sac, where is it going to accumulate? The top or the bottom?
Yeah, it's going to be posterior.
Yeah. So you have to understand where posterior is when we look at these views. And the big thing to understand is whatever's closest to the top of the probe is going to be anterior, and whatever's at the bottom is going to be the dependent portion. So when I'm in my parasternal long, I'm looking posteriorly, right, at the bottom of my screen for my effusion. When I talk about proper depth, I always want to see my descending thoracic, because this is a really important landmark when it comes to determining effusion. Because if I have a pleural effusion, I've run out of colors. If I have a pleural effusion, it is going to live deep to my descending thoracic, right? Because it's in the pleural space. Sometimes you'll see lung kind of floating in there, so something like bright white popping in and out. And you're going to see that fluid tracing the back wall of the thorax, so it's going to be a little bit curved. If it's pericardial, right, the pericardium lives in front of the descending thoracic. So what you're going to see is that fluid is going to be in front of my descending thoracic. So that's why it's so important to find this vertebral body and descending thoracic on your proper depth. Otherwise, if you're too shallow, you can mistake a pleural effusion, or you can completely miss pericardial. The other thing I see a lot of people make mistakes on is they're going to see a fat pad up here, and they're going to call that pericardial effusion. It's not unheard of, and Steve, you can probably correct me, you know better, right? It's unusual to have an isolated anteriorly located pericardial effusion. And so if you see fluid or something that looks like fluid here, anteriorly, so the top of the screen, but nothing at the bottom of the screen, I'm going to really start thinking that's probably fat pad and not a pericardial effusion. But if I see something down here that's fluids, right, anechoic, so it's going to be black. It's going to be in between my myocardium, so my muscle, right? There's my myocardium, and this is my pericardium. And then, so it's going to be black, it's going to be dependent, and in between those two structures. All right, so that's your parasternal long, right? So we're looking dependently. In our parasternal short, same thing, right? We're looking dependent. So I'm looking down here. Parasternal short is actually my favorite view for effusion because it's much simpler. There's so much less stuff going on that it's really easy. Sorry. It's really easy just to see effusion. Whereas like this one, there's just so many things going on. I feel like it's easy to miss it. All right. Apical 4, this one is gonna be awesome for looking for signs of early tamponade, and we'll go over that later. But really what I care about when there is an effusion is what is the right side of my heart doing? Specifically, my right atrium and my right ventricle. So is that effusion causing tamponade physiology? And I'm going to see it by early collapse of my right atrium or diastolic collapse of my right ventricle. And then the only caveat is our subxiphoid view. And when it comes to subxiphoid, you have to understand, right, we're imaging from down here. So now the dependent portion of the heart is going to be the closest to the probe. And the anterior portion is going to be a little bit further away. So that's why we use our subxiphoid view for our FAST exam, because anything that sits closer to the top of the probe is going to be crisper, clearer to see, whereas if it's really far at the bottom, it's going to be a little bit hazier. So for this guy, when I'm looking for pericardial effusion, I'm looking at the top of my screen. You guys understand that? So subxiphoid is my only special one where I'm looking at the top. Everything else,
Yes.
I'm looking at the bottom. And then my apical 4, I'm just focusing on what's going on my right side. Any questions on effusion?
No.
All right, awesome. All right, next one. What do you guys think?
Ejection fraction.
Yes, perfect. EF. I like to classify EF into 2 different ways to figure it out. For POCUS, I don't like measurements. I feel like for beginners, it's really easy to kind of mess up caliper placement and lead you astray on the EF determination. So I really much prefer eyeball. So when we're eyeballing EF, the 2 things I'm looking at is what is my valve doing, specifically my mitral valve, and what is my muscle doing? I'm going to put chamber in there too. So when it comes to valves for my mitral valve, there's 2 things I look at. One we call is the EPSS, otherwise known as the septal slapping. And then the other one is what we call MAPC. These are measurement, referring to the measurement, but I like just to eyeball these. So for EPSS, so it's E point septal separation. So your E wave, right, that's the early fill of your mitral valve. So it's how close does your mitral valve get to your septum when it opens in the first part of your diastole. The closer it gets, the better your squeeze. I like to think of EPSS as somebody jumping on a trampoline, right? The better their jump, the stronger they are, right, the higher they can jump. So the closer that valve gets to the ceiling, right, to the septum, the better the squeeze. So if I have a really strong person who can jump really, really, really high on their trampoline, their head is going to get really close to that ceiling. And that's a really nice, good squeeze. So I just eyeball it in power sternal long or in apical 4. I can look at how close does that valve, my anterior leaflet of my mitral valve, get towards my septum. The closer it gets, the better the squeeze. If I have, Nana on here, who's really old and can barely, she's got a cane, right? And she can barely jump. She's going to be really far from that ceiling. And so her function and her EPSS is going to be really diminished. So big space, poor EF, closed space or small space, good EF. So power sternal long, apical 4 are the 2 I can eyeball the EPSS. You can measure it with M mode, and you just put your ice pick right through that leaflet, how close it gets to the septum. And then you can actually measure the distance, but we don't have to talk about that today. The next valve that we do is MAPC, which is really just a fancy way of saying the mitral annular plane of systolic excursion. So how well does my lateral annulus of my mitral valve move? The more it moves back and forth, the smoother it moves and the more recoil, right, the better that function. You can eyeball it here. You measure it here in your apical 4. And again, you're just measuring the up and down. So if we go back to our little trampoline guy, EPSS is looking at the distance from my head to the ceiling when I jump. MAPC is just measuring the height of my jump. So the bigger that number, the better the move, the better that up and down motion, the better the EF. That makes sense. So anterior leaflet mitral
Yes.
valve, how close to the septum, and then lateral annulus, how well it moves up and down. The next one is your muscle and your chamber size. So I want to see with my muscle, can I appreciate the difference between systole and diastole, right? Does that muscle thicken up and thin? So thicken during systole, sorry, and thin out during diastole. So what I'd like to do is sometimes just stick my finger on each of the different walls and just look, okay, is that squeezing, is that squeezing, is that squeezing? If I can appreciate the difference and I can see the muscle wall thicken and it's pretty symmetric, then I say the EF is pretty good. The other thing I look at is the chamber. So how much does my chamber size change between systole, right, and diastole? A normal EF is about a 40% chamber size change. So when it comes to this one, my parasternal short is really my favorite view because it's just pure muscle and pure chamber. This one's pretty good, so you can use your parasternal long. And then my apical 4 is also really good. And then from the apical 4, like this one you can measure, they call like the Simpson method, or you can do fractional shortening. You can actually measure the chamber size in systole and then diastole, and the machine will spit out numbers for you. Again, that's more cardiology, not point of care, because we're more eyeball-y. And then even here for subxiphoid, you can also, if you have a nice clear subxiphoid, you can tell it EF from there. Caveats to these two things, you have to understand some limitations. So if I'm looking at my valve only, if I have mitral stenosis, if I have calcifications on my valve, or if I have AFib, it's going to mess up these eyeball measurements, right? Because if it's calcified, it's not, my MAPC is not going to move very well. If I have stenosis, my EPSS is going to be low, even though my EF will probably be fine. And if I have AFib, my heart's just doing all sorts of funky things. Some squeezes are good, some squeezes are bad. So it's hard to eyeball EF or AFib. If I'm looking just at muscle, if I have a bundle branch block, regional wall motion abnormality from prior MIs, if I'm paced, all of those are going to mess up your just looking at the pure muscle. So both of these kind of have to be taken into consideration when you're determining EF. And they should sort of check back on each other. And then each view should check back. So if this view tells me the EF is super low, but I look at my parasternal short and my EF looks totally normal, then I'm like, okay, one of these views is incorrect. And so maybe I either need a third to kind of be the tiebreaker, or I got to go back and figure out what was wrong with my initial view that led me astray. The last thing I'm going to say about parasternal short for EF is that it's really important when we're doing our EF that you are finding your papillary muscle. So we call it the mid-papillary view. Because if you look at the shape of the left ventricle, it's a football shape, right? So here's my valve. And then here's like, we'll say my papillary muscles, right? And so if I'm up here at the level of my valve, I have a lot of chamber, but not a lot of muscle. So what is my EF going to look like up there?
It might look
Flat.
lower.
Yeah, it's going to
Yeah.
look lower than normal. If I'm down here below my papillaries, here I have not a lot of chamber, but a lot of muscle. So now my EF is going to look artificially higher. So this one's going to make my EF look low. This one's going to make my EF look too high. And so that mid-papillary view has sort of the perfect amount of muscle to chamber. So that's like that Goldilocks spot. This also happens to be your best view for regional wall motion abnormalities. So if you're looking for like somebody who's complaining of chest pain and you're worried about ACS, you can't rule it out if they don't have wall motion abnormalities, but you can definitely rule it in if they don't have any prior history. And you see like one area, like say this spot here, your inferior wall is not squeezing very well. Any questions on EF? That's a lot. We're good? I'm gonna erase. Okay. All right, so moving on. So those are like kind of top three. The other two are a little sneaky. So there's entrance, which is literally just your IVC, which is kind of just a reminder to look at your IVC. Just a little caveat for IVC, it's really a reflection of the right side of the heart. And it reflects the right atrial filling pressure. It's not so much a marker for volume status. Because if you think about somebody who has like severe sepsis, and if they are third spacing everything, their IVC is going to be really small and kissing, but it doesn't mean that they're going to be responsive to fluids because they may already have pulmonary edema because they're just leaking fluid everywhere. Whereas if you have somebody who has right-sided heart failure and really bad tricuspid regurg, they could be volume down and dry, but have a really big IVC just because the right side doesn't work very well. So it's more this reflector, not a volume status. It's also really important to know where to look when you're looking for IVC. So the way you get it, so this is your parasternal long. You're going to rotate to get your parasternal short. To get your IVC, there's two places. You can either come in the center of their belly and make sure that your probe is rocked upward. So the beam is kind of aimed up towards the chest. And what you want to find is your liver and then the hepatic vein. And it's really super important that you find your hepatic vein because that's going to be your marker on where to look for your IVC collapsibility. We call the collapsibility index. You should also see it going through the diaphragm and then into the right atrium. And this is also another view you can kind of confirm pericardial effusion because you'll see it accumulated right here. So that's kind of cool when you see it there. When I'm looking for collapsibility, I'm looking right about the level of my hepatic vein. The textbook answer is 2 centimeters from the atrial cable junction, which is annoying because then you have to freeze, you have to measure, you have to look. It's fantastic. So literally, I just use my hepatic vein as sort of my marker, and I'm looking somewhere within that space. So you want to make sure, because if you're too far down the hepatic vein, the IVC, now you're getting intra-abdominal pressures, and it's not a good reflection of the right atrial filling pressure. And if you're too close to the diaphragm, now you're not going to get much collapsibility because the diaphragm tethers the IVC. Also, just know when you're ventilated or on BiPAP, the collapsibility index changes a little bit. And so the numbers aren't the same as if you're normally breathing. If you can't get IVC from the epigastric view, you can get it in the coronal view, just like your fast view. So on the side body, on the right side. Either way, and then the measurements are essentially the same. The other thing I really like for IVC is in long axis, but I also like to see it in short axis. So you'll see like the liver, and then you'll see the IVC, and you'll see the hepatic vein straining in. And then if there was a nice study that showed the size of the IVC and the roundness can correlate to your right atrial filling pressure, that CVP. So in short axis, if you're like really narrow and almondy shape, you have a low CVP. If you're a little more rounded, you have a normal CVP. And if you're super rounded and more than 2 centimeters in diameter from inner to inner, then you have a high CVP. And the way you get this view is you come here, the epigastric area, or your side view, and now you're just in transverse. Right? So here's my liver, and then here's my IVC coming in. So I'm just right over here. Last thing for IVC, just make sure you're on IVC and not aorta. Because if you're going to be doing like CVP estimations off of IVC and you're looking at the aorta, you're going to like put yourself in the wrong class. So you must see the structure should be right up against the liver, right? So if you notice the hepatic veins drain into my IVC, and my IVC is like touching, almost going through my liver. So you should see the IVC touching the liver and then the hepatic drain draining in. If I have my aorta, what happens is there's a little separation between it. But my aorta goes through my diaphragm as well, right? So I can't use it going through my diaphragm as my marker. Really what I'm looking at is it my hepatic vein draining into it? And is it going through my liver or is there a slight separation? Slight separation, this is aorta. Okay. And so if my entrance is my fourth E, what do you guys think the fifth E is? If I come in, I have to go out, yeah. I like putting valves in my exits just to remind myself to look at the valves, but when they talk about exit, they're really talking about the aorta. And so when I look at the aorta, this is looking for like aortic aneurysm. You want to measure it in your power sternal long. And you're going where the tip of the aortic valve leaflet is when they come together. So when you're just at the very end of systole, you're going to measure the outer wall to the inner wall. It's really weird. Cardiology does annoying things like that. Outer wall to inner wall. They also do all their echoes backwards than we do to make my brain hurt. But normal, the textbook answer is it's classified to your body surface area. But for us simpletons, we like females should be less than 3.5 centimeters and men should be less than 4 centimeters. So those are just kind of nice, easy reference numbers. When I look at valves, right, I can see it in my power sternal long. I can see them really well in my apical 4. I'm looking for their excursion. So how well do they open? And then their coaptation. How well do they close together? And you can see if you've got like mitral valve prolapse where the valves will come together and then one will kind of pop down behind it. You can see stenosis, right, where they don't open very well. And then you can see regurg where when they don't close very well, and you're going to get that color flow back. So the way to tell regurg, wish I had a blue marker, so I apologize. But if we come back to our color Doppler, pretend purple is blue for my colorblind people. Blue is meaning that the flow is going away from my probe. Red means the flow is going towards my probe. And if you're not sure, on the screen itself, when you put color Doppler on, it'll actually light up. It'll show you a little scale on the side. So the top is going to be the one that's going towards the probe color, and the bottom color is going to be going away from the probe color. So if we think about our normal cardiac flow, blood goes from the left atrium into my left ventricle. If I'm looking for mitral regurg, I need to put my color box over my entire atria, because that's how we grade our severity of regurg. And blood that's coming back into my atria is going to be blue. So if I see blue coming from my leaflet tips back into the structure, then I've got regurg. And then it's the same thing for tricuspid regurg, right? So if I have blue coming from my valves back into my right atrium, it's got tricuspid regurg. Everybody has like physiologic trace tricuspid regurg. That's super normal. When it comes to aortic regurg, if you think about the flow, right, blood comes into the left atrium, circles around, and then goes out my aorta. And my aorta lives right over here. My little aorta right here. So now if I have aortic regurg, the blood, instead of going out my aorta, right, is now regurgitating back into my left ventricle. And now I'm going to have a red jet going into my left atrium. So mitral tricuspid regurg is going to be blue into the atria. Aortic regurg is going to be red into the ventricle. And then other things for valves, you can look for like endocarditis or like little boogers sort of floating on the valves. You'll see like little stuff tethered. And then when the valve flaps, it's going to move with it. There's lots of things that can cause vegetations on valves that's not endocarditis, but in the right clinical setting, and you see something, we can have a high index of suspicion for. So that's our 5 E's. Any questions?
No,
I have a
Good.
question.
Yes, I love questions.
When you come back to your pericardial effusions, yeah. So not every effusion is just fluid, right? Like some of them are those complex effusions, and then sometimes in a ventilated patient, you might have like a pneumopericardium or something like that. What what are we going to be kind of looking for, or might tip us off in those sort of situations?
For fusion or tamponade?
No. Just like I'm just thinking. I was thinking like, what's it going to look like if there's like a pneumopericardium?
Oh,
Or
if there's a pneumopericardium, you're not gonna see anything. Air will completely obscure anything that you'll see.
yeah. So is it just going to make your echo just
You
blow
won't
it
get
up?
a view. I had one kid, it was a little kid, he had a pneumomediastinum. And like
Mhm.
I had no view up here, and I was like, what is going on? Everywhere I tried, I could not see anything. And then I went down and I was able to
Mhm.
get a subxiphoid view. Like that was it. And I was like,
I see.
something's weird. And I did an x-ray and you can see the outline of his pneumomediastinum. And I was like, that makes
I
sense
see.
why I couldn't find anything on him.
Okay. So that's kind of what's going to happen there.
Yep.
Okay. And then I just assume if there's a complex pericardial effusion, it's just not going to look so.
Yeah,
It'll look
usually
heterogeneous.
yeah, so it'll be heterogeneous. You'll see septations in there. I had one patient, if I can find the images, she had RA and had an effusion, and she had this like weird spider web looking complex pericardial effusion.
Gotcha.
If there's blood, so hemopericardium, you can get with like free wall rupture from MI, aortic dissection down into the pericardium, or obviously trauma, like stab wound to the chest. You're gonna see just like it'll be like tissue dense looking stuff sort of floating in there. I can show you. When we're done with like the lecture part, I'll pull up some images and let you
Okay.
guys show some.
Okay.
All right, let's go through right heart strain and then tamponade really fast. And then Steve, I know you have to leave soon, so just take off whenever, and then I will send you the recording. Hopefully recorded. So for right heart strain, I'm just gonna kind of focus in on the right heart. So here's my RA, here's my RV. Here's my pulmonary artery, and then to my lungs. So I'm gonna say all this in the setting of acute PE. And then my caveat is specifically with PE. If there's right heart strain, it's generally an indication that there's going to be some degree of instability. So whether it's tachycardia, so the heart rate greater than 110, or hypotension. So if you are doing an echo on somebody who has a normal right-sided right heart, doesn't mean they don't have a PE. It just means it's not large enough to cause any right heart strain. So if we think about the right ventricle with an acute obstruction in the pulmonary artery, the right ventricle is like a balloon. So if you blow up a balloon and you don't pinch that neck closed, the amount, no matter how much air you put in there, and it's not point to pop, but the amount of air you put in, the balloon is just going to push it right back out again. So that's your RV, right? Your RV loves preload, it hates afterload. So it can handle volume as long as there's nothing obstructing its outflow. The moment you take that balloon and now you pinch that neck closed, you put an obstruction in that artery, what happens to the RV? Or what happens to your balloon? Stays big, right? So the first thing you're going to see with right heart strain is RV dilation, which brings us to our equality, right? So our 1:1:1 ratio now becomes my RV gets big, and then everything else is 1:1. Or here, my RV gets bigger than my LV. That's the first thing that's going to clue you in. The next thing that happens is as my RV continues to get bigger, the RV is going to start to have more pressure and volume in it than my left ventricle. And I'm going to start getting septal bowing, or the D-shaped LV. And so what happens now is the pressure in my right ventricle overloads the pressure on my left, and that septum now starts to bow. And my LV starts to get, sorry, too many lines in here. My LV starts to become a D and my RV gets enlarged. The next thing that happens is because my annulus is connected to the RV, as the RV dilates, the annulus where the valve is connected is going to stretch. It's going to get bigger. But my valves are only so long. And so as my RV stretches, my valves are going to no longer touch when they close. So that blood is now going to regurgitate up into my RA. So now I get tricuspid regurg. If this is an acute process, my RV doesn't really get big because it doesn't quite have time. And so that blood's got to go somewhere. And the next thing that happens is my IVC dilates because the blood's just going to back up. And then what happens is all this blood is stuck on the right side of my heart. So my left side only can see what my RV can push out. And now my RV can't push out a lot of blood because there's this obstruction. So my LV starts to become hyperdynamic because it tries to compensate. And so it tries to push out every little last drop of blood. And it becomes underfilled. So you have this small little squashy LV and this big giant RV. And now you can understand why patients who have like right heart strain can get really hypotensive when that RV gets really big because the LV just can't fill. Other fancy things that you can look for is something called a McConnell sign. So what happens is as your RV dilates, the septum at the apex of the RV, it's tethered to the apex of the LV. And so when the LV squeezes, it pulls it this way. So it pulls your apex over. So this part of the right ventricle looks hyperdynamic. It looks like it's moving really well compared to the free wall. And it looks like it's not moving very well. So it's called McConnell's. It's like a regional wall motion abnormality that you're seeing. The other thing that happens as your RV gets overloaded, because of the enlargement, the function of the RV starts to drop. So now you get RV systolic dysfunction. And just like we can measure MAPC on the left side, we can measure TAPC, which is the tricuspid valve. And you're looking again at that up-down function. So if a big number is good, you're going to have a low TAPC. If you like numbers, it's going to be less than 1.7 centimeters when you measure how much up down it goes. Again, you can see all of these things with chronic right heart strain too. So if someone's got chronic pulmonary hypertension, they're going to have all of these, especially if they're volume overloaded. You're going to have septal bowing, you'll have tricuspid regurg, you'll get dilated IVC. You'll definitely have RV dilation. So one of the things you can look at to try to help you figure out if it's acute or chronic, a simple one is just looking at how thick is the myocardium of the RV. And the way we do it is in our subxiphoid view. And you're going to measure it at the very end of diastole. So when the wall is the thinnest is when we're going to measure it. And it's where the valve would hit. And you're just measuring the thickness of the valve. Sorry, the thickness of the wall. And it's the anterior wall. So you're going to use your subxiphoid view for it. And if that wall is less than 0.5 centimeters, that's acute. So if you have a thin RV wall, which it should be normally, and all these signs, that's acute right heart strain. If the RV wall is thick and all of this could all just be chronic changes that you're seeing.
So you're looking at the apex, right, Stephanie?
It's the free wall, but you're actually looking at it by the valve, so closer to the base.
Okay.
Although I'm going to tell you that you can still get like a PE or an MI on top of chronic right heart failure. So I have definitely missed PEs in these patients because I tried to be overly academic and was like, oh, this is all chronic stuff. And then the patient came back and they diagnosed their PE because somebody was like, oh, right heart strain, let me get a CT. So sometimes don't be overly smart and just think about PE when you see right heart strain. There was actually also a case report that they just presented where the patient had an aortic dissection. And the dissection, the aneurysm actually was pushing on the pulmonary artery and causing external compression. And then they had right heart strain from the external compression, which is other things that can cause right heart strain besides PE. Okay, last one, tamponade. You guys doing okay? Yes.
Yes,
I'll
I'm
take
good.
this.
Yep, doing okay.
Okay, so we talked about how to see where the effusion is. So the important thing I want to know is that effusion affecting the function? So tamponade, I'm going to tell you, my brain is no longer working. Should be an echocardiography diagnosis. I do not need to wait for my patient to be hypotensive or unstable to diagnose tamponade. Most patients in tamponade are actually hypertensive. And it's the same mechanism for like 3rd-degree heart block. So because of tamponade, right, it causes pressure on the right ventricle, and so it can no longer fill. So their stroke volume, the cardiac output is going to drop. And so your body's going to compensate initially for that decrease in stroke volume by increasing the systemic vascular resistance and causing some hypertension. So it's going to constrict his vessels. So you can be hypertensive with tamponade. So that doesn't mean you can't rule it out even if their blood pressure is normal. So I'm trying to think which view. Okay. So if we have our heart, here's my right side, here's my left side, here's my fluid. So I'll do it this way. My left side is much stronger than my right side. My right side is my little puny guy. And so when my left ventricle is going to fill and expand, right, that fluid has to go somewhere. So the left ventricle tells that fluid, don't pick on me. Go pick on that puny guy over there next to me. So that fluid is going to accumulate onto the right side of the heart. And if this is my atria, right, here's my ventricle, the puniest out of all of them is my atria. So the first place that the fluid is going to affect is the atrial function. And what's going to happen is my atria is going to get squashed inward when it tries to fill, because that fluid is going to exert its pressure on there. At some point, the atria is like, oh, stop picking on me, right? I got nothing left to give you. So that fluid is going to say, all right, fine. I'm going to go to the next weakest guy, which is the right ventricle. So you're going to get, the first one is going to be right atrial collapse. And depending on what resource you're looking at, it's either going to be systolic or diastolic, depending if they're talking about right atrial function or right ventricular function. So the right atria is going to collapse during its, when the internal pressure of the atria is at the lowest. And so it's at the lowest at the very end of systole, when it just ejected all that blood out. So at the end of atrial systole is when you're going to see it get squashed. So this is going to be the first one, right atrial collapse at the very end of atrial systole. It's a little bit hard to see. So this is like a very early sign. The next thing that's going to happen is as this starts to get affected, the right ventricle is going to start to get affected. And the same thing, the ventricle is going to get affected when it's at the lowest pressure. And so when it has the least amount of internal force to push against that fluid, which is going to be during diastole. So you're going to get right ventricular diastolic collapse. It can be really hard to figure out when you're looking at diastole and systole, because your eyeball is trying to track the valve, and then you're trying to track what that right ventricle is doing. So a really easy way to do it is going back to our friends EPSS. So you put your M mode right here, through the tip of the mitral valve and then through the RV. And what you're gonna get, so M mode, right, remember, it's only gonna detect motion that touches this line in the up-down function. So when we do our EPSS, what you're gonna see is the top line is gonna reflect like the pericardial sac. The next one, this is gonna be your effusion. The next line you're gonna get is your RV, so this is gonna be your RV free wall. Then you're gonna get your septum. And then this is going to be the blood in my RV. The next thing I'm gonna see is my mitral valve. So my mitral valve is gonna open. This is your E wave, right? So there's my EPSS. There's my early fill. This is my atrial kick, and then it's gonna close and it's gonna open again. So this is diastole. I know it's diastole because my valve is moved towards my septum. So my valve opens towards my septum. Right, here's my septum, here's my valve. I'm in diastole. Does that make sense? And then when my valve closes, it moves away from my septum. And this is systole. And then you'll see the back wall of my LV. And then you'll see that posterior effusion. So now in this view, I can figure out when's diastole and when's systole. Normally, when you're in diastole, right, your RV fills. So if my RV is filling, it's moving away from my septum, right? So my valve opens, it moves towards my septum in diastole, and my RV fills and moves away from my septum. So both these guys are moving in the same direction. This is normal. No tamponade. What happens when there's tamponade, right, is now my RV closes. It's squashy during diastole. So now I'm in diastole. My mitral valve is opening normally, it's towards my septum, but now all of a sudden, my RV is getting squashed. So my RV is collapsing and moving inward during diastole. And so now when they move towards each other, you're in tamponade. So this is tamponade. Does that make sense? Tampode. That's really, it makes sense when I explain it, but like if you look at it, you're like, what? Did you guys get it? So
Yeah, that makes sense.
move towards each other, tamponade. Move same direction, normal. I'm gonna just say tamponade's a fluid state, right? It's very preload dependent. So if you have somebody, so they came in because they syncopized, they're a little volume down, they got a pericardial effusion, you do your echo and you're like, oh crap, there's tamponade. What do we do? Where we try to temporize them, right? We give them fluids. So now you increase the preload of your right side of your heart, which increases the pressure inside the heart and gives it more strength to push against that fluid. And so you could take them from early tamponade with right atrial collapse, give them fluid and it'll go away. So don't feel like a failure if you do an echo and you're like, there's tamponade, and then cardiology does it after they're resuscitated and it's not there anymore. That's just, it's normal. That's kind of like the way the physiology works. You fixed them.
Okay.
I think that's like the basic staff